Our next speaker is Dr. Helen Spicer-Cain, who's coming up to the lectern now. So Helen and her colleagues received a grant from the Heather van der Lely Foundation entitled Very Early Predictors of Grammatical, Phonological and School Readiness Skills at School Age in Siblings with Communication Disorders. And I think that's actually the title of your talk, isn't it?
Thank you for coming to listen, and I need to say a massive thank you before we start to Heather van der Lely and the Heather van der Lely Foundation for the opportunities that there have been through this project for me. My project is covering a massive topic. Like everybody, I've had to cut it down for today, so there's only particular aspects of this data that I'm going to be able to talk about, but we have lots and lots of other interesting findings coming out of this work that we will be able to publish later. So, yes, basically I'm going to talk about not so much about predictors today, but about what happens with language, different types of language skills and social communication skills at school age in siblings of children with communication disorders. Okay, so I'm going to start for you with a little bit of background. Part of the driver for my work is looking at how we spot children who have communication difficulties early in life. As Julie said, this is an audience that very much understands the purpose of identification of needs and why spotting communication difficulties are important. So I think we all know that growing up with a communication disorder of any type carries a substantial risk of later socio-emotional, behavioural and educational difficulties, particularly if that communication disorder is unidentified and unsupported. There's also growing literature that suggests that early intervention can be effective for improving communication. So we know that there's a risk if early intervention doesn't happen, and we know that early interventions can be effective. But research is also telling us that children in the UK rarely have access to early interventions because they're rarely spotted and identified with needs early enough to get the right supports put in place. So basically, the driver for the whole of my work is this big need to work out if we can identify earlier in their life those children who may need ongoing support. So, how did we decide to go about this? Well, this starts with my doctoral work, which has continued into the funded project, where we've basically decided on the methodology of studying increased likelihood siblings. And we have two groups of increased likelihood siblings in the study. And just to say a little word for those of you who might know less about the increased likelihood sibling literature. First of all, we know that recurrence rates of autism in siblings of diagnosed children are substantially higher than autism prevalence in the general population. So if you have an autistic sibling, if they're a full sibling, you're about 8 times more likely to receive an autism diagnosis, and if it's a half sibling, about 5 times more likely. We also know that siblings who don't receive autism diagnoses are more likely to display features associated with autism. And what's not well understood is whether these are autistic children who are being missed or whether actually these are siblings who are simply showing a broader autism phenotype characterisation in that they share some of their siblings' features, but not enough to receive a diagnosis. We also know that these children are more likely to experience language difficulties. So if you have autistic siblings, about 40% of children with autistic siblings will experience language delay or language difficulties at some point in their life. What we also know from research is that outcomes of increased likelihood groups are highly heterogeneous. So although increased likelihood is important, we don't really know, and I have to say, still haven't really disentangled with this work, what picks out increased likelihood children who go on to have difficulties from those who don't. So, one of my increased likelihood groups are children who have autistic or possibly autistic siblings, and I'm going to say a bit more about how the groups are characterised in a minute. But we've also been looking at children with increased genetic likelihood of language disorders, and this group is so much less studied in the literature. If you search for children at increased likelihood with autism, you'll bring up hundreds of papers and systematic reviews and all sorts of things. If you start looking at children with higher genetic likelihood of language disorder, the number drops very significantly. But we do know that there's an association of family history of language and or literacy difficulties with lower language ability. in both directions. So actually, if you take children who have difficulties with language and literacy, they are more likely to have family members who also have those difficulties. And if you look at the siblings of children with language disorder, they are more likely to have language difficulties. We also know that amongst all increased likelihood siblings, this second group is less spoken about, and also a lot of the current literature focuses on children up to the age of 3, and there's much more limited discussion of early childhood and early school age outcomes. There is some, but it's much less extensive. So, thankfully, the grant that we received from the Heather van der Lely Foundation has allowed us to try and add to that literature that's out there about both this second increased likelihood group and about what increased likelihood children look like slightly later than 3. And slightly later than we originally intended because of COVID. So, what did we do? So, these are the groups that we have in my study. We have 3 groups of children. The children in the blue box are children who have average likelihood of communication difficulties. So these are children for whom, on significant discussion with parents and questionnaire measures, we know that parents and siblings have no known developmental conditions that would impact on language literacy or communication. In the green box, we have our IASCD group, who have increased likelihood of social communication difficulties. And this group is a broader group than in some of the increased likelihood literature, because we wanted not just to include children whose parents, siblings and half-siblings have a confirmed autism diagnosis, but also those who were whose siblings were under assessment for diagnosis, where siblings had been identified by parents and professionals as having social communication difficulties, or where we saw on the Children's Communication Checklist 2 profiles that look like those of autistic children amongst the siblings. So we've got quite a broad approach to defining this group. And then we've got our third group in the orange box. These are our ILLI group, who have increased likelihood of language and literacy difficulties, where we know that at least one of their parents, siblings or half-siblings have a history of difficulties with language, so either current difficulties with language or history of language difficulties, or late talking, or literacy difficulties and or diagnosis of dyslexia. So broad groups, but actually these are much more like the types of likelihood that we see in practice, where people are not so neatly characterised by diagnosis. So these are the children we're talking about. And we're looking at a group who I first recruited during my doctoral work when they were infants. So at the first time point of the study, we started with 92 infants across quite a broad age range, but mean age 13 months, 51 in the average likelihood group, 18 in the ILSCD group, and 23 in the ILLI group. Some of these infants, although not all, so a sample of 28 were followed up at age 3, and then the funding from the Heather van der Lely Foundation allowed us to do a time 3 follow-up of 62 children between the ages of 6 and 8, so mean age 7 years, 2 months. And very neatly, this included 31 average likelihood children and 31 increased likelihood children spread across the 2 groups. So what have we done with these children? Well, we have quite an extensive data set that takes in multiple types of measures. At time 1, we recorded infants in free play with parents, and we there, as such, have a whole raft of data on different elements of their spontaneous communication skills. But we also assessed them with the Preschool Language Scales 4th edition. We used the UK CDI checklist, the Communication and Symbolic Behaviour Scales Infant Toddler checklist, the Modified Checklist for Autism in Toddlers, and some novel dynamic assessment measures, which I'm not speaking about today, but we did have a paper published about them last year if you're interested, and there will eventually be some follow-up about what the age 7 data point tells us about predictive ability of some of those measures. We had a small time 2 follow-up at age 2 to 3, like I said, but really what I'm focusing on today is the data from time 3, which due to COVID was collected over Zoom with children in their homes. And this is quite an extensive battery of stuff that involves Raven's matrices, CEL5, GAPS, the Bracken School Readiness Assessment, concepts of print, naming speed, narrative, the Pragmatics Activities Checklist, which is scored by the researcher on the CEL5, and also parent reports using the Children's Communication Checklist 2 and the Social Responsiveness Scale 2nd edition. So wide variety of data. So, although I'm mostly talking about the time 3 data today, I'm going to give you a little brief characterisation of what we already knew about these groups when we went into the funded project. So what did we find out at time 1? Well, we found out that our increased likelihood of social communication difficulties group scored significantly differently from the other 2 groups on many of the measures taken in infancy, particularly including lower receptive language scores on multiple types of receptive language measures, and higher levels of features that would be associated with autism measured using the modified checklist for autism in toddlers. They also, interestingly, this group had an expressive language dominant profile on both parent report and experimenter administered measures. As a group, expressive language is comparatively stronger than receptive language, which is a pattern that's often seen amongst young autistic children. And that wasn't just a few children in the group driving that pattern, that appeared to be a general kind of sibling thing, however good their language was. The increased likelihood of social communication difficulties group also lacked typical associations of many scores on many measures with age, which is really surprising finding, because when you run a correlation between scores on a standard measure and age, you expect to find them. And actually, the other 2 groups, they're there, and in this group, they're just not there. So we know that something about their development is proceeding differently from the other groups. And although our increased likelihood of language impairment group mostly didn't look different from the average likelihood children, they did lack typical patterns of association between language measures and social communication measures, suggesting that there's some disconnect somewhere in their abilities that should be correlated. So something different happening there as well. And hopefully we will have a paper available soon where you can read about that data. And although we didn't follow up many of the children at time 2, and we had very small numbers of children that were followed up, there were a couple of things that were worth highlighting, particularly that there were children showing signs of speech, language and communication needs in all groups, but most particularly, and I wouldn't like to make too much of 8 children, but the vast, vast majority of the ILSCD children who we saw at the age of 2 to 3 had some degree of speech, language or communication difficulty. And not only were they more likely to have that difficulty, those difficulties appeared to be more severe and more pervasive than the needs of children in the other 2 groups. So all 3 children who fall into the purple section with both delayed language and social communication difficulties at age 2 to 3 are increased likelihood of social communication disorder children. So our previous research told us that this group was looking highly vulnerable to lower scores on lots of measures and a very different pattern of development. And up to that point, we hadn't found any real differences in our ILLI group from the average likelihood group. So, I'll tell you a bit more about what happened at time 3. And I've got 4 main findings that I'm going to discuss with you from the time 3 data collection. First of all, some average likelihood children get diagnoses too. So I'm going to address this point on the next couple of slides. Also, something we didn't expect to find, likelihood status is movable. And when you think about the previous literature, again, I'll go into this in a bit more detail, but we should have expected it and didn't. And then about the results themselves, our ILSCD children still differ from their average likelihood counterparts pretty much across the board. So cognitive, language, phonological awareness and social communication skills. And the ILLI group only show significant differences from the average likelihood group on parent report measures and not on standardised measures. So I'm going to pick up all of these threads in a minute. But let's start with this first point. Average likelihood children get diagnosed too. So the boxes now show you the numbers of diagnoses or suspected diagnoses that we have in each of the groups. And you'll see in the blue box, we have some autism diagnosis, a further child undergoing autism assessment and some children with literacy difficulties. Once again, in the middle green box, we have quite a lot of difficulties or resolved difficulties. And then there are also some difficulties in the orange box. So basically, diagnoses or difficulties, identification of difficulties at time 3 isn't restricted to the increased likelihood groups. Now, we never really, on the basis of population prevalence, thought it would be. But we have quite a lot of diagnosis in this average likelihood group for 31 children. So this has led us to some quite big methodological questions. What do you do with average likelihood children who later receive a diagnosis? They are technically average likelihood if you're dividing on the basis of likelihood groups, but they also receive diagnoses, and how does that interplay? So maybe some need to look at the results by outcomes as well as by likelihood groups. So on the basis of population prevalence, we should always expect some average likelihood children to have difficulties, but it's rarely discussed in the literature on increased likelihood children that there are any children in that group who receive diagnoses. And so if anybody has done any increased likelihood work, I'd be really interested to hear whether other people have found something similar. On to my second point, likelihood status is movable. So again, this was something that really surprised us. We really thought that, like seems to happen in other studies, we're going to categorise children in infancy about their likelihood, and then we're going to work with those groups as they grow older. Well, when we saw the children at time 3, we saw 62 children, and if we applied the same criteria as we had applied at time 1, 10 children would change likelihood group. So 10 out of 62 is quite a lot. So there were 4 children who would move from the increased likelihood of language impairment group to the ILSCD group because their elder siblings looked like they had language impairment when they were younger and now look like they have autistic features or autism diagnosis or social communication difficulties. Similarly, 4 from the average likelihood group would also move into that ILSCD group because their elder siblings now have autism diagnoses or are being assessed for autism. And a couple that would move from the average likelihood to the increased likelihood of language impairment group because we now know their siblings have literacy problems. And in addition, we have a further 6 children who have younger siblings with communication difficulties. And although likelihood is normally determined on the basis of older siblings, there's a big question then about what do younger siblings mean for the genetic profile of those families. So it's not useful clinically to know that younger siblings mean something, but if you're thinking theoretically, what does that tell us about those families? So a few thoughts about this. Previous research tends to use sibling diagnosis as a specifier, but our groups are broader. They include children where we've got parental concern, who are under assessment for difficulties, as well as those that score within clinical ranges on parent report measures. So it's possible that some of this movement is simply caused by having broader groups, but actually, I don't think so. I actually think that in longer longitudinal studies, it's definitely possible and indeed probable that some children, the elder siblings, receive a diagnosis or a different diagnosis between research time points, based on what we know about the average age of autism diagnosis. For example, if you're recruiting children in infancy, a lot of their elder siblings are only 2 or 3 years old, and we know that there's a massive increase in autism diagnosis between age 4 and age 8. So actually, you should expect that more children will have elder siblings with diagnoses who didn't have diagnoses before. And so actually, this shouldn't have been a surprise, but it was. We also might expect this movement from the ILI to the ILSCD group, because we know there's previous literature showing that profiles of SLCN change over time, so that children identified in childhood with language disorder do show more social communication difficulties and a more social communication-y profile as they age. So we also should have expected that movement, but we didn't. And the reasons that we didn't are because actually in longitudinal increased likelihood studies, children are rarely followed up to a point where elder sibling diagnosis might change or elder sibling literacy status might be known, or where younger siblings might be identified with need. So we said already that most of the increased likelihood children studies stop at age 3. They actually then are not picking up these effects about how likelihood status changes. So basically, throwing this open, we don't know what to do about this. If anybody has any ideas, please do speak to me. For now, we've left the likelihood classifications as they were when the children were infants in order to analyse the data. but we are in an ongoing debate about whether we should change them, whether we should go back to the infant data, knowing what we know now about their likelihood status. All of this is sort of up for discussion. So those are my two kind of methodological points. Average likelihood children get diagnosed too, and likelihood status is movable. So without completely undermining my field of research, I think there are some interesting methodological points here for us to discuss. Be that as it may, I'm going to sort of move on now to what some of the results are in the way we have the children categorised currently. So you're going to see lots of graphs. They've all got the average likelihood children in the leftmost column, the ILSCD in the middle, and the ILLI on the right, and the significant differences have got stars. The error bars are one standard deviation. And I'm just going to talk you through how the groups look different on some of the measures that were used at time 3. So the first measure is Raven's matrices. And despite the fact that all group means fall within the average range, there is a significantly lower score for the ILSCD group with a large effect size. So we know that these children are not scoring as well on a measure of non-verbal skills as the other children. And I've looked into this to see whether this was 1 or 2 children pulling the group mean down, and it's not. There are a couple of vastly lower scores, but the scores are in general just lower. So this is also a complicating factor that I'll bring up again about the rest of the results. So then what happens if we look at receptive language using the CAL5? Well, all the group means fall within the average range, but you'll see how high the group means are for the average likelihood and ILLI groups. This is, I should have said, this is a very high maternal education sample, just like the sample that Julie was talking about. So they seem to have very high group means, and the ILSCD group seems to have a roughly average group mean. So they are, again, although average, falling behind the other children in the study in terms of their receptive language. And if you enter the Raven's score as a covariate, this difference disappears. So there's something about the relationship between language and cognitive skills in this middle group that we don't really yet want to propose directionality on. It may be that lower cognitive ability is leading to lower language skills, but it also could be that lower language skills are leading to more difficulties solving non-verbal tasks, because although we know that they're really tasks that require non-verbal responses, we know that they may need verbal processing to actually think them through. You get the same pattern for expressive language. Basically, this ILSCD group are still lower at language than the other groups, but some of that does appear to be related to the difference in their non-verbal score. So when we move away from language, we looked at phonological awareness using the preschool inventory of preschool and primary inventory of phonological awareness. We've used raw scores because, sadly, due to the COVID modification, some of the children slightly aged out of the optimal age group for the task. But despite that, we did still find some group differences. And surprisingly, I was looking for the ILLI group to be poorer at phonological awareness, which they're not, but the ILSCD group, for whom you might not expect a difference in phonological awareness, show one. And again, it's related to the Raven score, but it's also related to some other interesting patterns in the data. So I collected this data, and anecdotally, my feeling was that the children in the ILSCD group were not necessarily poorer at phonological awareness, but they were poorer at understanding what the tasks wanted them to do. So you don't see this group difference when you look at specific components of phonological awareness. When you look at rhyme awareness, alliteration awareness, letter knowledge, they look fine. It's on syllable segmentation and phoneme segmentation where anecdotally my feeling was that many of the children struggled to understand the tasks. And actually, if you look at the correlations for this group, although it's a very small group, so we'll be a little bit wary, language has a really significant relationship with phonological awareness in this group, more so than in the other two groups. So my feeling is actually this may be something related to language and understanding of the task that's driving this difference for that group, but could still be impacting on their literacy because it possibly still impacts their ability to access phonics instruction at school. Okay, so non-word repetition using the gaps. The children were very high near the ceiling, but despite the ceiling effect, we got potential for differences between groups on a test in slightly younger groups or where there would be less ceiling. So yes, it didn't reach significance, but there's a medium effect, and our feeling is that had we had a slightly more sensitive measure for this age, had they not aged, basically, while we were making COVID modifications, we might have found an effect here. And the effect is actually in both increased likelihood groups being lower than the average likelihood group. So actually, this is where we've started to see some differences in the ILLI group. And we know from Heather's research and others that non-word repetition is a particularly good marker task for language difficulties, including resolved language difficulties. So the N over here didn't reach significance, and I sort of looked at the data in a different way and looked at how many children in each group received a score of 6 or lower out of 8 on the non-word repetition, and it's significantly more likely that you would receive a lower score if you're in an increased likelihood group. So there is something going on with this task, even if we don't quite get the significant effect in the ANOVA. So moving on the CAL5 pragmatics activities checklist, which is scored by the experimenter, and the scoring here is reversed. So a higher score indicates more pragmatic difficulties, and a 0 score indicates kind of very limited pragmatic difficulties. Again, we didn't get significance, but we do see that that ILSCD group has an elevated amount, and particularly a very large standard deviation in terms of their experimenter-rated social communication skills. So what happens when we go on to parent report? Well, here we got another interesting effect. So using the social responsiveness scale, which potentially highlights autistic features, again, we found that both increased likelihood groups differ from the average likelihood group in that children receive elevated scores on this task, and in the case of the ILSCD group, the mean score is close to the beginning of the range of clinical interest on this task. So, interestingly, this one doesn't have an effect of co-varying the non-verbal IQ. So that appears not to make a difference in how your parents identify potential autistic features, and those potential autistic features seem to be higher in both groups and evident on most of the SRS2 subscales. Now, again, this high score in the ILLI group could be potentially unexpected, but because there's been so little work done on ILLI children, particularly none of it has looked in detail at their social communication, except potentially one study that I think of particularly by Tomlin in 2003, which suggested that siblings of children with SLI did have increased incidence of autism, so that the risk was crossing over. So that's what I'm thinking of when I'm looking at this. And then with the general communication composite on the CCC2, we also, once again, see lower scores indicating more parent-reported communication needs in the ILSCD group, with a large effect size and, again, no impact of IQ. And particularly these difficulties relate to subscales that cover syntax, semantics, initiation, and stereotyped language. So they're not all social communication or pragmatic subscales. Some of them are linguistic subscales. We have looked at some other areas. We found no significant differences between groups for naming speed, letter knowledge, concept knowledge, or, interestingly, the CCC2 social interaction deviance composite, which is not an acronym I like, but interestingly found no differences there. And again, I think there's something to unpick in why the SRS2 shows differences, but the SIDC doesn't. So, coming on to a little bit of discussion for the last few minutes. We recognise some significant limitations of the study. First of all, it's a relatively small sample size, particularly in the ILSCD group. Bigger groups would allow more accurate judgment. But we are also quite impressed that we managed to retain 2/3 of the sample in a COVID time point administration that was 6 years later than they were originally seen. But we need bigger groups. We also need a more diverse range of children across a broader range of SES, because we know that we've got a high maternal education sample. We're not sure whether that's preventing us from seeing some of the effects that might be present, or whether that's, for example, meaning that effects show up where they might not. Because actually, particularly, for example, when we looked at the KELF scores, the ILSCD group's mean is within the average range, but it's significantly lower than the other two groups. And that could be an artefact of how high the other two groups are potentially because of their maternal education level. We have to acknowledge that this was an online assessment and that there's more limited evidence, although there is some, for reliability and validity of online assessment, but it appeared valid and reliable. We looked at 4 correlations with age, 4 correlations between measures, 4 correlations between subtests, and found that the data looked sensible. So we're hoping that it's good. We've got real-life groups that are broader than some other studies. So that affects some of the interpretation in light of previous literature, but we also feel it's potentially more representative of actual increased likelihood than some of the studies that use tighter criteria. There's also an issue around sensitivity of measures. So we've used a lot of standardised measures there that might drive towards language disorders or autistic features, but we know that those are biased towards particular presentations. So, for example, the SRS2 and the CCC2 are instruments with a lot of research behind them, but are not necessarily neurodiversity affirming and may be biased towards a particular autism presentation. And it may be that they are not the only or the best instruments. And I think this is an area of discussion for us for the future. And I've also acknowledged the changes in sibling status and the diagnosis in the AL group as potential things we have to think about. So what are our future directions? Well, we took narrative measures, both receptive and expressive narrative, at time 3 using Peter and the Cat and the Peter and the Cat narrative comprehension assessment that we've really yet to analyse. So based on what Judy just said about the importance of narrative, I'm interested to see what comes out of those. And we're also still analysing relationships between time 1 and time 3 measures, and we're particularly interested in potential predictive ability of the dynamic assessment measures that we established at time 1. And we have plans for lots more publications and for a dissemination event for families and professionals about what we found from the study so far. So my lovely postdoc Abby will be working on that over the next few months. So what are the conclusions? Well, average likelihood children get diagnosed too. Likelihood status can shift over time. And possibly lots of shorter longitudinal studies haven't been long enough to find this effect in the past. Most importantly for me, children at increased likelihood of social communication difficulties show differences from average likelihood children in infancy, as toddlers, and still at early school age. Potentially they've got lower scores in language, in phonological awareness, almost in non-word repetition, and they're showing more communication and social communication difficulties on parent report measures. So there's definitely some vulnerability to language difficulties and social communication difficulties in that group, and in the group as a whole, not just in specific children. So there's some needs there that need to be thought about. And our ILLI group, who didn't look any different from the other groups or from the average likelihood group as infants, have started to show some differences. Non-word repetition, although we didn't quite get a significant result, and in higher T-scores on the SRS2. So it may be that parents are picking up some differences in communication and everyday interaction that we are not seeing in a one-to-one, quite standardised formal assessment session. So my key point, I'd really like to see increased developmental surveillance of and support for increased likelihood children. Lots of parents in the study anecdotally are still struggling to get support and diagnoses for their increased likelihood child, and there appears to be poor understanding of the vulnerability that may exist among increased likelihood children. So I think I'd like to see more done in that sphere. And some acknowledgements to the parents and children who took part in the study at all 3 time points, to City University of London for my doctoral funding, particularly to the Heather van der Lely Foundation and Heather van der Lely herself for the opportunity to expand on this work, and then also to my key collaborators Nikki Botting and Abby Moran, who are up there, and also Natalie Hassan and Bernard Camilleri, who have worked alongside me in some of this work. And I'm almost dead on 35 minutes.